Welcome to our Facebook Live session about measurable residual disease, MRD, and blood cancer. I am your host, Rachel Sack, Senior Director of Education and Outreach at the Cancer Support Community. For more than 35 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help provide emotional support and empower people to be active in their own care. You can access our free services in person at one of our 175 locations online or over our toll-free helpline. You'll be able to work with a team of licensed professionals who can provide patient navigation, financial counseling, genetic counseling, pediatric support, and more. I would like to thank Amgen for their generous support for making this program possible today. Now, I would like to introduce today's speaker. Dr. Aaron Logan is an associate professor of clinical medicine at the University of California, San Francisco, and the Division of Hematology and Blood and Marrow Transplantation. His clinical practice includes a focus on the management of patients with acute leukemias and myelodysplastic syndromes. Thank you for joining us today, Dr. Logan.
My pleasure. Thank you for having me.
Absolutely. Dr. Logan will help us better understand today's topics of measurable residual disease, which is also sometimes referred to as minimal residual disease. To make things simpler for all of us, we'll call it MRD. Does that sound okay, Dr. Logan?
Absolutely.
Great. MRD testing can be helpful for treating patients with blood cancers such as acute lymphoblastic leukemia, or ALL for short. Measuring the number of remaining cancer cells in the body can help doctors and patients make informed treatment decisions. It also increases the chances of complete and lasting remission. I would love to ask you some questions today, Dr. Logan, so that we can all better understand this important new test. Then we will ask some questions from our live audience. Every person diagnosed with cancer hopes for complete and lasting remission. But we know that one of the hardest things about cancer is that it sometimes hides from treatment. Even when it seems like complete remission has been achieved, there may be cancer cells left behind that scans or lab tests just can't detect. That's where MRD comes into play. At CSC, Cancer Support Community, we heard from people living with ALL. They want to know more and why they should consider MRD testing. Dr. Logan, can you tell us what exactly is MRD?
Absolutely. So again, thank you for having me today. When we first meet a patient who has a blood cancer such as leukemia, they have trillions and trillions of cancer cells in their body. And we can easily detect that by just checking their blood. And conventionally, we also do a bone marrow biopsy to get material of the leukemia for diagnostic testing. And then we give them some treatment. In the setting of acute lymphoblastic leukemia or ALL, we give multiple different chemotherapy drugs that kill the cancer cells in different ways. And we go from a lot of leukemia cells, if you could graph it out, a very high number of leukemia cells to a very low number that, initial chemotherapy doesn't, unfortunately, kill every single cancer cell in the body. And so in the past, we had very insensitive ways of assessing how people were responding to therapy. And we could say whether they got into a remission, which is a point in time when the leukemia has been reduced enough that the normal function of the bone marrow can return, and we can see resumption of the manufacturing of normal white blood cells and red blood cells and platelets. But until recent years, we weren't really able to detect how deep was that remission. And so through various different research and clinical trial studies, we now have a better understanding and better methodologies for measuring that little bit of disease that's left. And as you mentioned, it used to be called minimal residual disease. And many of us in the field now believe that the better terminology is measurable residual disease. It's the little bit that we can now measure with more sensitive techniques. And we can take that MRD measurement, and we can use that information to assess whether patients are achieving very deep remissions, meaning the chemotherapy is working really well, Or is their remission more shallow and there's still some residual leukemia cells there left, maybe 1 out of 1,000, 1 out of 10,000, or so on, of the white blood cells in the bone marrow may still be detectable leukemia cells. And so now we can use that information to help guide our therapy so that we can individualize how we're treating leukemia patients, so that those patients who are doing really well with chemotherapy can stick with it, whereas those who maybe aren't doing so well with chemotherapy and are fated to eventually relapse from that residual disease, we can maybe do something different to prevent that from happening.
Great. Thank you for breaking that down for us so simplistically for such a complicated issue. Can you tell us how long MRD testing has been used? And if this test is only for blood cancers, or is it better for certain types of blood cancers such as ALL than others?
Yeah, it's a great question. So acute lymphoblastic leukemia, or ALL, is actually the most common cancer in children. There's a little over 3,000 children diagnosed every year. So not a large number, but it's still the most common cancer in children. And so most of what we originally learned about MRD was in the setting of trials done by a consortium called the Children's Oncology Group. And this is still an existing consortium that's very successful at getting children with ALL into clinical trials. And they very early on, more than 15 years ago, started to incorporate MRD measurements into their clinical trials, so that as patients were going through their therapy and they were having an assessment of their response, there was also an assessment of the MRD. And so from many different children's oncology group studies, the field of hematology started to learn that this is a very important marker of disease response. And so there are now other studies also in adults that have looked at MRD. And the aggregate of that information has shown us that in ALL in particular, it's critically important to look at MRD at different time points after patients start therapy so that we can see how they're responding. It turns out this is also applicable to other blood cancers. So there's another acute leukemia, acute myelogenous leukemia. And we now know that looking at MRD in AML, acute myelogenous leukemia, is important. Similarly, in other blood cancers such as chronic lymphocytic leukemia and multiple myeloma, there's evidence that looking at MRD can be prognostically significant. As for other cancer types, there is ongoing research looking at whether there might be ways of assessing MRD, for instance, in patients who have breast cancer or colon cancer or lung cancer. It's a little bit harder because, in the blood cancer field, we have the advantage that we can access the cancer cells in the blood or in the bone marrow. We stick a needle into the hip and we aspirate the liquid marrow. Whereas with a solid tumor, there might just be one or a few tumor masses and the cells may not really be in circulation. So the research that's ongoing for solid tumors is looking at what's called cell-free DNA. In other words, the genetic material that's liberated from cancer cells when they break down and does get into the blood. And now with very sensitive next generation sequencing techniques, we can look for mutations related to the cancer. And if we can detect those in the blood, then maybe that would be prognostic significance for solid tumors. So that's a developing area of research. In many ways, it's technologically harder to do than the techniques that we'll talk about for blood cancers, because for blood cancers, again, there are various things about them that make them easier to measure. But I do think that eventually the field of oncology and hematology is going to move towards trying to detect residual disease in as many tumor types as possible, so that early on we can figure out who's doing well and who might benefit from modifying their therapy.
Well, we'll hold you to it. In a couple years, 5 to 10, or maybe even sooner, we'll get you back on with me and we'll start talking about that too. It's exciting.
Absolutely.
Thank you. So it sounds like being able to detect whether there are any leftover cancer cells is very important. Should people living with ALL or any other type of blood cancer ask for an MRD test for their doctor if they haven't brought it up? And how do they know when to ask for that?
Yeah, I think that as of today, there are still a very small percentage of patients who independently are aware of MRD and the importance of it. There are some very savvy patients who do their own research after they get a diagnosis and they can look online. I and others in the field have tried to create resources online that patients can learn about MRD so that they can ask about it. In particular, for adults with ALL, the treatment is distributed across many, many different cancer centers across the United States. Is not as well organized as the Children's Oncology Group studies, because adults are busy, they have work lives, they have family lives, and a lot of times they don't want to uproot themselves and go to a different city for therapy. And so they might get treated at a local cancer clinic, and that practitioner there, MD or NP, whoever they see, may not be as familiar with ALL. And so I do think that there's a lot of value to educational things such as this broadcast and other things that people can find on the web to learn about MRD so they can ask. But it ultimately is the responsibility of the treating provider to make sure that they are ordering the test at the right time and understanding the test results, because not all the tests are created equal. Some are better than others, some are more sensitive than others, some are more specific than others. But I do think that there's a great opportunity for communication and collaboration between patients and their doctors, and patients really can and should ask, hey doc, did you get an MRD test? What did it show? How do you interpret the results? What does it mean about how I'm doing with my therapy? Those are the types of discussions that we should be having, because we endeavor to have our patients informed about their diagnosis and about their therapy and how things are going, so that we can have that conversation about when we unfortunately sometimes need to change track and say, okay, this thing isn't going to lead to a long-term disease-free survival or cure. Maybe we're gonna have to switch to this other track. And that could be something really scary, like a bone marrow transplant or something like that. And I think it's good to have that conversation early on about how we make those decisions.
Can you tell us, sometimes it's hard for patients to question their doctor or suggest a test, they're not comfortable.
Mhm.
How you would recommend that a patient would approach that with their doctor or a nurse practitioner if they
Well,
feel that they're starting to question things?
yeah, I think it's a great question. I think that the vast majority of providers in medicine and oncology in particular are not really going to feel threatened by a question. And, what I recommend to patients is, they could say, hey, I was reading about my diagnosis and I learned about this thing called MRD, and we haven't discussed it yet. Is this something you're planning to get for me? I'd really like to understand when we're going to get that and how we're going to use those results. And just, ask the question, because there are oncologists around the country who may treat only 1 or 2 ALL patients per year, and maybe they're not quite up to date on, how to get the testing done. But that question from a patient is going to prompt them to say, oh, well, let me go look into that. And that doctor will very easily be able to find resources to get the right testing done. So I encourage patients to advocate for themselves, ask questions. Don't be afraid to ask questions. It's absolutely, you're right.
Great. And we always encourage our patients at CSCs and try to empower them. And if they feel that they need help, they could always ask somebody else on their healthcare team or social worker to go into a meeting with them, with one of their healthcare providers to ask those questions.
For sure.
Okay, great. Can you tell us, are there any risks with MRD testing?
Not really. I mean, the testing is done either by getting a sample of blood or more frequently a sample of the bone marrow at different time points as patients go through therapy. Patients undergo bone marrow biopsies many, many times, unfortunately, while they're going through therapy. So it's not generally adding any additional risk. There is a minor risk, theoretically, that an MRD test could come back and falsely show that there's more disease burden than there actually is. The tests that we typically send these days have a very, very, very low likelihood of being false positive for MRD, but there's a theoretical risk that a physician could get a test result that shows more disease burden than there actually is. Usually it's the converse. Usually the result may be a false negative because maybe the bone marrow sample is diluted with too much blood and it's not really assessing the result or the level of disease burden. So I think the risks are very minor. And these days we do advocate doing MRD testing in a serial fashion or repeatedly as patients go through their therapy, so that if they had a positive result and you give them a therapy and you want to see the result of that, you get the test again and see, well, did it actually make a difference? Or if they were negative before, there's still some risk that it can become positive again. So if you give them more therapy and you reassess their MRD and you see that they went from negative to positive, then you can make an intervention on that. So by having multiple time points of testing, I think it really decreases the risk of an error in therapy being made.
Perfect. That's actually was my next question. So thank you for touching on that about when MRD testing should be used and how often a patient should get that MRD testing.
I can speak a little more specifically about that.
Great.
So in ALL, we have different modules of therapy. So, the first module is what we call induction. We're trying to induce remission. And usually this is multiple different chemotherapy agents. So at the end of that first module, which is usually about a month long, there's a bone marrow biopsy done to assess whether the patient got into remission with that chemotherapy or not. And that is the first and probably most important time points to assess MRD. So what is the quality of that first remission assessment that they achieve? So at the end of induction, we get MRD. And then as patients go through other modules of therapy, which include consolidation, which is more chemotherapy to consolidate the remission or make the remission better, there should be a repeated assessment of MRD. And then if patients are not going to transplant, they'll eventually go on to what we call maintenance therapy. And during maintenance therapy, which is lower intensity chemotherapy meant to maintain the remission, there should again be some different time points where patients get MRD assessments to make sure that that's actually working and that the disease burden isn't starting to creep its way back up, because there can be interventions during the MRD progression before a frank relapse that can be very meaningful. And then similarly, if patients are going to a transplant because either they previously had MRD that was treated or they have high-risk genetic features associated with their leukemia that have already been shown to convey a high risk of relapse, and the doctor decides to take them to a transplant, we do typically assess MRD prior to the transplant and then at multiple time points after the transplant. So again, MRD assessment is something that really should be built in as a serial test at different time points as patients are going through their therapy.
Perfect. Thank you. And I'm sure that the physician can outline that, and that as things change, that can be reassessed through the course of treatment.
Absolutely.
Okay, great. So a lot of our patients come to us, those who are considering participating in clinical trials. With MRD testing, that would be still applicable if somebody's in a clinical trial?
Absolutely. So many, if not most, of the acute leukemia trials these days are incorporating some MRD assessments. Usually with any bone marrow biopsy that's done to assess response, there will now be a trial-associated MRD assessment, because one of the things that we're looking at in the field is not only are these novel therapies that are coming to trials helping patients achieve remission, but are they achieving high quality MRD negative remissions, meaning no detectable MRD? That's what we want to achieve. So most trials are going to incorporate MRD testing. And we also now have trials that are specifically targeted at patients who got standard of care chemotherapy and then were found to be in remission, but have MRD. They have detectable disease. And, this is a scenario that we want to apply therapies to figure out, can we erase the MRD and make that little bit of disease go away? As we can talk about, there is an MRD eraser, quote unquote, for acute lymphoblastic leukemia, which is an approved therapy for MRD positive B-cell ALL. But we don't have MRD erasers for AML or other cancers. And so we are developing clinical trials that patients with MRD positivity might be able to get involved in to figure out whether we can erase their MRD and improve their outcome.
Wow, thank you. So let's get a little bit more into some of the details. Since ALL is more common in children, teens, and young adults, and you've mentioned that, are there any special considerations around testing for this younger population? And can you tell us how you walk parents through this? Because when you have young children, this can be extremely overwhelming, and one more test is just one more test, and
Sure.
it can get confusing.
So, full disclosure, I'm an adult hematologist. I don't treat children. But the considerations with children really depend on the age of the child and their size, because there is a limit to the amount of blood that you can draw from a small baby or a small toddler. There is a limit to the number of bone marrow biopsies that you would want to do, because children typically need to be sedated to undergo a bone marrow biopsy, whereas with adults, we can do it under local anesthesia. So my pediatric colleagues definitely take those types of things into consideration. And I think, even though I haven't done this myself, I think the conversation would revolve around, what are the most essential time points that we need to assess the response in the bone marrow of your child with this disease? And what are the tests we're going to do? How are we going to take the small volume that we're going to get? And how are we going to maximize the information that we can get from that bone marrow biopsy? And one of the most important pieces of information is going to be the MRD testing. So I think that's going to be part of that conversation about why it's important to take a little bit of that volume and send it for an MRD test.
Perfect. So is this something that can be done at the doctor's office? And a lot of patients come and ask us, is it painful? Does the test require local anesthesia or general anesthesia?
So for leukemias in general, we are going to be performing MRD on the bone marrow biopsy. And a bone marrow biopsy, honestly, does involve some pain. Typically, we will perform it on the back of the hip, where the hip bone is very close to the surface of the skin. And we'll numb up that area with local anesthetic. Sometimes if patients are nervous, we can give them some medicine to help calm them down, or we can give them some pain medicine. Some centers will sedate even adults for bone marrow biopsies. Many centers don't, because the risk of the anesthesia is actually higher than the risk of the bone marrow biopsy procedure itself. So usually it's done by numbing up that area of the bone, and then we just stick a needle directly through the skin into the bone, and we can aspirate or remove into a syringe the liquid marrow inside the bone. And that gives us the sample that we need to send for various tests, including the MRD test. So that's the very first part of the bone marrow biopsy. And then usually we'll move the needle and we'll take a small solid piece of the bone. It's called a core biopsy. So like when you take a core of a tree to get its age by counting the rings, we can use a small needle to take a core of the bone marrow biopsy, and it gives us a little segment about 1 centimeter or 2 long, and pathologists can cut that real thin and look at it on a microscope slide and stain it with different things to look at the arrangement of the cells in the bone marrow. So there is a little bit of pain involved with the bone marrow biopsy, but patients are going to have bone marrow biopsies anyways, even if their doctor isn't getting MRD testing. So the MRD testing itself is not adding anything uncomfortable. We are trying to determine, could we prevent the need for some of these bone marrow biopsies by checking the blood? And there is a test that's available for MRD assessment in ALL, which is extremely sensitive. And we now have studies that are looking at, is it sensitive enough that we can detect the tiny little bit of MRD in the blood and maybe not need to look in the marrow as frequently? That's data that's developing right now. We can't recommend not doing bone marrow biopsies right now and instead just doing the blood, but eventually we may be able to get there.
That's great. So I think, and I just want to see if you have any additional information you want to add on how the blood or bone marrow sample is tested in the lab.
Sure. So usually the biopsy is done in the oncologist's office. Some centers may send a patient to a different provider called an interventional radiologist, and the radiologist might actually use imaging, either a CT scan or some kind of imaging to guide their needle into the bone. That's usually not necessary, but some centers do that just because their clinic isn't set up to do the biopsy. But once the sample is acquired, that liquid sample of marrow does need to be sent to a laboratory that has the competency to do an MRD assessment. So that varies from one place to another. At very large academic centers, they may do the MRD assessment in their own clinical lab. And the most common way of doing that would be using a test called flow cytometry. And flow cytometry is a test where a sample that has cells in it can be stained with antibodies that have little fluorescent molecules attached to them. And you can put a mixture of 6 to 8 or sometimes even more antibodies with these fluorescent molecules in so that they all bind to the surface of the cell. And then those stained cells go through a machine, and cell by cell on an individual basis, the machine will interrogate using lasers to activate those little fluorescent molecules. What proteins did those antibodies bind to on the surface? And then it tells you what each of those cells is based on the expression of proteins. And we can use that test if we know the what we call phenotype, which is the different types of proteins expressed on a cell, the phenotype of the cell. We can quantify the cells that have the phenotype of a leukemia cell. So that's a common method of MRD quantification. Some academic centers do it internally. Some, including ours, even though we're a large center here at UCSF, if we want MRD testing, we actually send it to a reference lab that has developed an assay that's highly reliable, and they can quantify cells down to 1 leukemia cell out of 10,000 white blood cells, or 0.01%. So that's the minimum level of sensitivity that we really require to have an accurate MRD assessment, is 0.01%. Now, there is another test that uses a different technology. And this is not as broadly applicable because it only applies to leukemia cells or blood cancers that go through a process of genetic rearrangement at genes that express what we call immunoreceptors. And these are the receptors that tell an immune cell what it's ultimately going to respond to in life. And that's how our immune system has diversity and the ability to respond to lots of different bacteria and viruses and funguses that we encounter just by living on Earth. So in those types of cancers that derive from cells that undergo that genetic rearrangement, we can use that specific genetic rearrangement as a naturally occurring genetic barcode to identify the cancer cells. And there's actually an FDA-approved test for ALL, as well as CLL, chronic lymphocytic leukemia, and multiple myeloma, that uses that genetic barcode as a method for quantifying the residual disease. And the advantage of this test is it's very, very specific, because that genetic sequence that arises through a random rearrangement of a specific immunoreceptor locus is going to be very specific to the cancer. Additionally, because it takes advantage of what we call next generation sequencing, which allows for a lot of data to be captured in a very small amount of time, we can get a deeper assessment of the MRD in patients. This goes to 1 out of 1,000,000 cells. So 1 leukemia cell out of 1,000,000 white blood cells. So that's 0.0001%. So it's 100 times more sensitive than the flow cytometry. So that is a test that can't be done in even an academic center's own lab. It needs to be sent to the vendor that has the FDA-approved test available. And so, here at UCSF, that's the test that we use for MRD assessment for our ALL patients. And it does take about a week to get those results back, but that's timely enough for us to make decisions. And the increased sensitivity allows us to make decisions, hopefully in a better way than the less sensitive tests. Now, in the middle of that is some patients will have a genetic change that's not related to their immunoreceptors, but specifically related to their leukemia. So an example of this is about 20% of ALL patients have a specific translocation where 2 pieces of chromosome swap pieces. Chromosome 9 and chromosome 22 swap pieces. And this makes a new protein that doesn't normally exist in cells called BCR-ABL. And this is what we call pH positive or Philadelphia chromosome positive ALL. It represents about 20% of adults with ALL. So in those patients, we actually have a different genetic assay that looks specifically at that new protein BCR-ABL and the gene that gives rise to it. And we can quantify that as a specific marker for disease. And that test has a sensitivity that's in between the flow cytometry and the next generation sequencing of immune receptors. It's around 0.001%, which is 1 out of 100,000 white blood cells, or 10 to the minus 5 is the other annotation. So we have these different methodologies, and different centers will gravitate towards using one or the other just based on what's easiest for their lab or their send out lab, or the contracts that they can get with these companies that provide the tests.
Wow, that was a lot of amazing information. Thank you. So
It's
I think
complex, but hopefully
No,
we
it
can
was
break it down
great.
to make it a little bit more simple.
No, it's great. I think you answered my next 3 questions. So it sounds like that it can take anywhere from a few days to up to, if you're sending it out to a vendor, which is what your facility prefers, about a week or so.
That's
But that based on where you're sending it and what you're particularly looking for and the level of sensitivity, you can gain so much information that can really help provide outcomes, better outcomes and interventions, and give both you and your patient the level of knowledge that they need to make decisions.
absolutely.
That's
Without
great.
those sensitive tests, the limit of sensitivity is generally around 1% to 0.1%, which is 1 out of 1,000. So these technologies really are going deeper to give us a better assessment of the treatment response. And our field is now gravitated towards deciding that patients who don't achieve a remission with MRD that's less than 0.01%, or that 1 out of 10,000, are not doing well enough on their therapy, and we will frequently switch to a different therapy and many times transplant those patients to increase their likelihood of being cured.
Great. And when the test comes back negative, I know we talked a little bit about that, but what would your next step be? To retest, to wait and see?
So when patients get a negative MRD test, it means that the therapy that they have received is doing well, and typically they'll remain on that therapy. And at a later time, usually 1 to 3 months later, depending on where they are in the course of their therapy, they'll get another MRD assessment to make sure that it's still negative. And if it went from negative to positive, there may be a clinical decision to change their therapy to prevent that MRD positivity from becoming a frank relapse.
Perfect. So let's talk a little more specifically about people living with ALL whose MRD test comes back positive. We understand that there's a drug approved by the FDA just for measurable residual disease in ALL. Can you tell us a little bit more about this?
Absolutely. So ALL really is, I think, the poster child for how the rest of oncology will evolve. And again, it's because for years now, we've been learning about MRD through children's studies and now adult studies. And it's the first disease in which there was a therapy that successfully was shown to take patients who are MRD positive and render them MRD negative. And this therapy is called blinatumomab. The other name is Blincyto. And what this drug is it's actually an immune therapy. It uses the patient's own immune system to eradicate the residual leukemia cells. And simplistically, you can think of it as 2 different antibody fragments that are stuck together. One antibody fragment actually binds to a molecule called CD19 on the surface of the B cell ALL leukemia cells. The other side of the antibody binds to a protein called CD3 that's present on cells called T cells, specifically cytotoxic T cells. Those cytotoxic T cells, when they're brought in proximity to the leukemia cells by this little antibody fragment that brings them together, the cytotoxic T cells can then kill the leukemia cells. So what blinatumomab or Blincyto does is it's a small protein. We infuse it constantly because it has a short half-life. We infuse it continuously for 28 days. And for that full 28 days, we're bringing immune cells to the surface of the leukemia cells and allowing the immune cells to eradicate them. And there was a study many, many years ago that showed that blinatumomab has an 80% success rate at taking patients who are MRD positive and making them MRD negative. And so this is now approved by the FDA for MRD positive ALL. It remains, as of today, November 4th, 2021, it remains the only therapy that's specifically approved to treat MRD in any disease. And it's a very important decision for patients taking care of ALL patients to make, so that if their patients are MRD positive, they can potentially switch from chemotherapy, give them blinatumomab to render them MRD negative. And then in most cases, those patients will ultimately go on to a bone marrow transplant as a curative route for their leukemia. In some cases, patients may not go on to transplant and may go back to other forms of therapy to maintain their remission. And the field is trying to figure out now, are there patients who could do well with just the blinatumomab for MRD and not necessarily need the transplant? But we haven't quite figured that out yet. So in general, we're going to take patients to a bone marrow transplant after they get blinatumomab in that MRD setting.
Great. That's incredible. Incredible work being done. Finally, I want to talk to you a little bit about cost. Many new tests are expensive. Is MRD expensive? Does insurance cover it? And, you know, if you don't have insurance, what do we tell patients? How do we help them with this?
Yeah, so, unfortunately, the reality is everything in American medicine is expensive. I think everyone watching today probably has a story of getting a bill for a clinic visit or an ER visit, or, certainly cancer-related care that looks astronomically expensive. Even simple blood tests are usually a couple $100. A blood count, a chemistry panel, usually a couple $100 there. So MRD testing generally costs somewhere between $1,000 and about $2,000 for the test, depending on which test is being done, where it's being done, which lab it's sent to. And in the vast majority of cases, what we do in American medicine is we get what's called prior authorization from the insurance company to do the testing that we're planning to do on the bone marrow or the peripheral blood. And generally, there's going to be an approval, and the approval from insurance companies is actually getting, for MRD, is getting easier over time because there is now more and more data showing just how important it is. We now have clinical intervention that we can make, such as giving blinatumomab for patients with MRD positive disease. So it is now uncommon for us to get a denial from an insurance company to cover the MRD test. It does still happen sometimes. And, usually the company that provides the test is obligated legally, if they don't get paid by the insurance company, they're obligated legally to send a bill to the patient. In most cases, the company providing the test will have a patient assistance program so that they're not paying that $1,000 or $2,000 for the test. They're paying hopefully a much smaller fraction of that. And I think that, the companies, their hearts are in the right place. They develop these tests because they want to help patients get the best care. They want to help patients have the best outcomes. And, I can tell you from interacting with them, they don't like billing patients, but they're legally obligated to when the insurance company doesn't pay. But they really do try and help patients with their patient assistance program. So yes, there are some cases where a patient may have a out-of-pocket expense related to their MRD testing. And I think it's just important for them to talk with their doctor and find out, is there anything else that the doctor's office can do to appeal the decision from insurance, to maybe get it covered. We go through that all the time. I appeal many decisions in various different settings from insurance companies. And an appeal means I'm providing the insurance company with the evidence that I'm using to make the decision to get this test or to give this therapy. And so, if their expert in this field maybe isn't thinking about it the same way, I have an opportunity to say to them, well, these are the papers that I think are relevant that have been published, and this is my clinical rationale. And, many times, not always, I'm able to convince the insurance company to reverse that decision and to cover the test or cover the therapy that we want.
Great. And I know as a former practicing social worker in an infusion center, there are grants that are available, financial assistance, and things of that nature. So we want patients to get the treatment that they need to get. and find out what they need to find out, and we'll help them through it. So thank you for that.
Absolutely.
So I guess as we approach 2022, if you can tell us, Dr. Logan, what is your hope for the future of MRD testing? What are your wishes in terms of what we see happening in the next 2 to 5 to 10 years?
Mhm. Well, in ALL specifically, I think what we need to do is more studies with this very highly sensitive methodology using next generation sequencing that can quantify leukemia cells at 1 leukemic cell out of 1 million white blood cells, and determine for those patients who do achieve MRD that's detectable below 0.01%. So maybe they have 1 out of 100,000 white blood cells, or even 1 out of 1 million. Is that a level where we should still make a decision, such as giving blinatumomab or changing therapy or doing a bone marrow transplant? Those remain unanswered questions in the field, and there are studies that are looking to answer those questions. Additionally, as I mentioned before, I think there's some potential for this very highly sensitive test to allow us to test the blood and maybe not need to look in the bone marrow as frequently. And if we can get rid of some of those bone marrow biopsies that are uncomfortable for everyone, and for, again, the very small children, more meaningful because you can only take a small volume anyways, if we can just test the blood, that would be hugely impactful. So there are studies now looking at whether the blood versus the bone marrow assessment can be useful for making the same clinical decisions. And I think ALL is going to be the disease where we figure that out. Now, going beyond ALL, I think the broader field of MRD assessment does have some challenges outside of ALL, CLL, and multiple myeloma, where we can use this technology that takes advantage of the immunoreceptor rearrangements. But in diseases like acute myelogenous leukemia and myelodysplastic syndromes and other bone marrow disorders, assessing for MRD is more challenging. We can use flow cytometry, and there are studies that have shown flow cytometry is useful for predicting responses in AML. We don't yet have a therapy to give AML patients who are MRD positive. It's a very difficult situation to have an MRD positive AML patient because we know that that conveys a high risk of relapse, even with a bone marrow transplant. But we don't yet have a blinatumomab-like therapy for AML to erase the MRD and make the transplant work better. So there are studies ongoing, including at our center, to look at whether there are ways to get rid of MRD in AML. And then similarly in other diseases, in multiple myeloma is another disease where MRD assessment is quite common. The field there is trying to figure out, for patients who achieve MRD negativity, can they be taken off of their maintenance therapy at an earlier time point? If they become MRD positive, what is the best therapy to give them? There are similar agents to blinatumomab that are being developed, have been developed for multiple myeloma that will be looked at for treating MRD. So that's going to happen in multiple myeloma as well. So hopefully over the next 5 years, we really figure out, what do those very low levels of disease burden mean? Should we make earlier clinical decisions? Can we test the blood instead of the bone marrow? And can we apply this to all blood cancers, any liquid tumor basically in the blood or the bone marrow where it's easy to access the cells? And hopefully what we learn in blood cancers will ultimately be applicable for some of the solid tumors using cell-free DNA. Again, there's some different challenges there, but hopefully some of the same principles can apply, that if a patient with breast cancer has residual disease detectable in cell-free DNA, maybe you could apply an immune therapy to get rid of those residual cells. So I'm very optimistic for cancer care in general, that we're ultimately going to get to a point where we make earlier decisions in the course of therapy to improve the quality of the remission and cure more patients, hopefully with less toxic therapy.
That sounds all positive and truly amazing. And we wish the same as well. So you already answered one of our questions about multiple myeloma and if there was a drug that was similar. And it sounds like that there's research being done in that arena. One last question came in from the audience. If you can just point us to some additional resources that people would refer to for MRD testing, and questions they can ask their doctor.
Absolutely. So There are various organizations that have created content online for learning about MRD. There's some content from the Leukemia and Lymphoma Society. The Leukemia and Lymphoma Society also sponsored the creation of a website called ALL Explained, which is ALLXPLAINED. So they're explained without the E, ALL Explained. That goes through the course of a patient with ALL, and it describes MRD testing at different time points and the interventions that are made on it. So that's, I think, a great resource. I contributed to that website. There's another website that was also sponsored by Amgen, who sponsored this talk today, called Catalyst, CATALL for ALLYST, Catalyst, which is meant to be a center, a website for both patients and healthcare providers to learn about MRD and the test methodologies for quantifying it and how to apply that information. And so if you Google ALL MRD, you'll find the Catalyst website, and hopefully that can be a resource for people. Usually through Google, people will be able to find these resources. And I do recommend that patients Google to find information about their disease, but also be careful about going too deep into the rabbit hole, because a lot of times the information that they may find may be, less refined or less up to date. And sometimes it can be a little confusing or a little bit scary for patients who may not be able to interpret the data. So if they have questions, they can ask their doctor, or they can ask one of the nurses in the clinic that they're at, like, hey, do you think this is reliable information? Or do you think there's something better I can look at? There are very many resources for people to look at.
Well, thank you so much.
Absolutely.
So at the end of this discussion, it just sounds like there's a lot of optimism that you have and that we have here at CSC for what's being done, future research, and what the future holds for these patients. Can you offer any last piece of advice for our patients battling some of these diseases?
Yeah, I think, I always tell my patients that, blood cancers in particular, one of the most difficult things about them is they just drop into your life, really usually without any forewarning, and they just turn everything upside down. Acute leukemia, ALL or AML, is called acute because it happens so quickly. And so patients can go from feeling relatively well to being very, very sick from their leukemia over a short period of time. And then, they're in the hospital, they're getting all this testing done. And then all of a sudden they're getting told, you've got a cancer, it's cancer of the blood system, you're going to need therapy. Usually for ALL, that therapy means they'll spend the next month after their diagnosis in the hospital. And that's a big change in their lives. And so I think it's really hard early on to adapt to this information and start to incorporate it. And I think everyone experiences, some sense of emotional numbness where their life feels like it's just, falling apart. And, what I recommend to people is take it day by day, learn as much as you can. Don't be afraid to ask the same question of your doctor or the nurses in the hospital multiple times, so that you can really start to understand what are the things that the team that's taking care of you is looking at in terms of how you're tolerating your therapy, whether the toxicities that you may be experiencing are managed well enough. Some drugs unfortunately may cause nausea, or they may cause other side effects. So make sure that you're reporting those side effects, so that you can get drugs that can help treat the side effects and help you feel better. But then ultimately start asking questions about, okay, well, how are we going to assess, how I'm responding to this? How will we decide to make decisions about whether this is the right therapy for me? And that's where their conversation will start to incorporate things like MRD, to help the patient understand, what is the doctor going to do to ultimately decide after the first month or the second month or the third month of therapy, whether they're on the right track or whether they need to think about something maybe more intensive like a bone marrow transplant. And it really requires patients to just roll with the punches. take in and absorb the information. But in ALL or AML or any blood cancer, I really think there's a lot of reason to be hopeful, a lot of reason to be optimistic. I always tell every single acute leukemia patient I meet, irrespective of their age, my goal when I meet you is to cure you, because acute leukemia is a curable disease. Now, do we end up curing everyone? Unfortunately, no. But when we meet someone, the goal is cure. And, really what I recommend patients is be optimistic. Let's work together to make sure that we are, getting you through the therapy as easily as possible, as comfortably as possible. Taking into account the patient's goals. Not everyone necessarily wants to go through intensive therapy. If somebody's 80 years old and they feel like they don't want to spend a lot of time in the hospital towards the end of their life, that's a conversation to have with their doctor. And, sometimes the goal doesn't necessarily need to be cure, but maybe palliation, getting the leukemia and the symptoms from it under some control for a period of time to maximize the quality of life if it's thought that the amount of time that's remaining is on the shorter side. So these are all important conversations, and I think patients can be optimistic that we have many different therapies to use these days. We do cure an increasing proportion of patients with acute leukemias and other blood cancers, and that's going to get better over time because we are getting more and more therapies, coming through trials and getting approved by the FDA. Please be optimistic if you are facing one of these diseases.
Well, we love that optimism here at CSC, Dr. Logan. So thank you so much for an informative and wonderful talk. We wish you and everybody on this call a happy and healthy upcoming holiday season and a happy and healthy 2022. And we want to thank Amgen, our sponsor, again for this program. Thanks, Dr. Logan. We truly appreciate it.
Thank you so much.